That gets us to the next type of patients who are between about 4 to 5 diopters to about 10 diopters or more. And what would be your choice? So I would have Dr. Gitansha talking about SMILE.
You want to give the price now only or in the end?
Later. The prize is to be announced later. Dr. Kavita Rao talking about Contura, and Dr. Reshma Javeri talking to us about ICL. So Gitansha.
Thank you, ma'am. A very good afternoon to all of you. I'm Dr. Gitansha Sachdev. I'm a cataract and refractive surgeon with the Eye Foundation Group of Hospitals. So, over the next 4 minutes or so, I'd like to explain why SMILE is my procedure of choice for moderate to high myopia. I have no financial disclosure. Now, why are we still facing this dilemma between SMILE and LASIK? A number of meta analyses and reviews have shown that there is no difference between the two in terms of safety and efficacy of visual outcomes. But there are a lot of other advantages that SMILE has over LASIK. One is that there is a reduced induction of spherical abrasions with SMILE. We all know that the excimer in the LASIK has a peripheral loss of fluence, because of which we can induce spherical aberrations intraoperatively. SMILE maintains the asphericity of the cornea, so much so that the newer machines are actually factoring in the Q factor or the Q value preoperatively in order to maintain the asphericity of the cornea after the procedure is over. The optic zone reduction in SMILE is lower as compared to LASIK. Also, you're not severing or making a cut, and the ablation of the excimer induces more inflammation and more wound healing response. And once you raise the flap, the lower surface or the residual bed is in contact with the inflammatory mediators of the tear film. None of this happens in SMILE, so the risk of spherical abrasion induction is lower. This has been shown in terms of lower cell apoptosis and lower inflammation markers as well. The next important thing is postoperative dry eye. We all know that the severance of the corneal nerves can result in dry eye up to 6 months postoperatively. SMILE obviously has a much smaller cut, which results in lower incidence of dry eye, which has been shown in numerous publications, be it the density, the number, the branchings of the nerve fibers as late as 6 months, or even multiple studies which show that the corneal sensitivity in SMILE comes back much earlier vis-a-vis LASIK. So this obviously translates to lower dry eye symptoms in patients, be it the TBUT, the osmolarity, or even the OSTI. Biomechanical superiority is something that is very well known and perhaps one of the major advantages of SMILE, because the stronger anterior collagen lamellae are left intact with the lenticule as against both PRK and LASIK. And also the Bowman's layer is either severed or ablated in LASIK and PRK and is left intact in SMILE. We obviously have no flap related complications such as just losing the flap or even a displacement, and striatal epithelial ingrowth are less likely vis-a-vis LASIK. There's no need for an excimer laser. It's a quicker procedure. You don't need to move the patient between machines, and external factors like the stromal bed hydration or the humidity have no impact. When we compare it with phakic intraocular lenses, yes, in terms of the efficacy of visual outcomes, the results are similar, but we can't forget the safety. Also, SMILE is an extraocular procedure. It's definitely easier to perform than to teach a person how to implant an ICL. The pre-op assessment in an ICL requires a lot more clinical acumen, and if you have a wrong size ICL, you can induce visually important complications like a pupillary block glaucoma or even a cataract. Phakic IOLs have a lot of vision threatening complications, especially the earlier ones with decompensation of the cornea, bullous keratopathy. The risk of RD ranges from almost 3 to 7%, which is obviously not the case with SMILE. There are risks of cataracts as well, which then subsequently require a lens explantation. The risk of endophthalmitis is, though exceedingly low, is still not a risk which I would be willing to take as a surgeon. So I just like to conclude that SMILE, with its increased biomechanical stability and lower dry eye vis-a-vis other ketorefractive procedures, and obviously its safety vis-a-vis ICL because it's an extraocular procedure, would be my procedure of choice for a moderate to a high myopia. Thank you.
Next, we have Dr. Kavita Rao.
Thank you very much, ma'am, for having me at this session. I'm Dr. Kavita Rao, and I'm an LVP and Shankar Netralaya alumni both. But I must say that Rupal ma'am has been my first guru for refractive surgery, so I definitely owe that to her. And I'm glad that Gitansha brought up a lot of points, which I'm going to obviously refer to in my talk. My talk here is that why Contura LASIK in moderate to high myopia. So that we are debating versus SMILE and versus ICL. So I think that let's talk about raising the bar in refractive surgery. We all are talking only about getting a 6/6 vision, but is that the benchmark? We need to look beyond this, and we know that there are more components of vision. We need to look at near vision, asthenopia, depth of focus, corneal aberrations, understanding the cylinder. I'm glad she pointed out that the lenticule is getting aberration free in the newer machines, so not so in the current machine for the lenticule based surgery. So like she's also said, we need to understand about Q value, asphericity of the cornea, corneal aberration. So just a quick revision, a normal cornea is prolate and it's a negative aberration. It means that the shape flattens from the center to the periphery, and in a sphere, basically it steepens towards the periphery. So when the pupil becomes larger, the cornea has spherical aberrations, you get all those night vision symptoms. So how is Contura laser different? Basically, it is different in the way the laser is fired, the way the corneal aberrations are treated, the way the cylinder is treated, the Q value, and the pupil and the limbus registration, especially compensating for cyclotorsion if you have a high cylindrical number, which is not, you cannot possibly do that with most of the machines for SMILE. Now, how is it different? I don't know if that image is seen, and this is just a representative image. It's not exactly this is how it happens, but in a wavefront optimized laser, the laser is fired uniformly in the center, so definitely it causes what she mentioned, that because it gets flatter, it causes aberrations. But we are talking about Contura, so the central steepness is always maintained. So her point is absolutely invalid that that it's going to not maintain aspherical cornea. In Contura, that's not true. Contura versus wavefront optimized, we need to know we are not talking about any LASIK, but Contura LASIK. The results are much superior in terms of predictability and also in terms of visual results. Here, let's look at the study published by the Narayana Netralaya group, where they've compared the LASIK versus SMILE and PRK. I found it really interesting. What they've done is they've measured the depth of focus, and what they found is that there are lesser corneal aberrations and better depth of focus. The accommodation is also better in Contura versus SMILE, and it is also worst in trans PRK. Sorry, Syed Maz, but it is worst in that. So in an older patient, probably it's better to use Contura because you're losing depth of focus. And of course, we are talking about patients who are fit. I'm not talking about patients who are, thickness is low. We are all talking about patients who are fit for all three categories of surgeries out here. So moving on from this, why Contura? It treats corneal aberrations. It maintains the asphericity most definitely. It improves depth of focus versus SMILE. It treats the entire cylinder. I think Rohit Shetty has been talking about this ad nauseum, that the cylinder comprises of the anterior and posterior corneal curvature and corneal aberrations, which current lenticular based machines do not treat. Why not SMILE? Cannot treat the aberrations. Better depth of focus, and also there's more tissue loss. To the best of my understanding, I do all the three techniques of surgeries, and I definitely feel there's more tissue loss in SMILE versus LASIK. Maybe the more experts can comment on that. SMILE has limitations. I don't think high myopia can really be treated with high cylinders, inaccurate cylinder correction. ICL, she's wonderfully pointed out all the bad things about ICL, and I fully agree with her. ICL has glare. It is an invasive surgery, endophthalmitis, cataract, glaucoma, so Reshma, sorry, but there's no scope for you. let's raise the bar in refractive surgery and Contura LASIK. So thank you.
Next, I think Reshma is waiting there to prove that I think ICL is the best possible surgery.
Yeah, I think I've been put at a very difficult position, but of course, till we get this, can you start this? I think one thing that's common between all of us is about Rupal ma'am, because she has been for me also. She, for my first surgery was done with her almost about 16, 17 years back, and she's such a sweet teacher. It's unbelievable. It's just the best. So yes, please a big round of applause to Rupal ma'am. Yeah, mother of smile. She, because she always carries that smile also all the time. Yes. Yeah, if I knew it's a debate like that, I would have probably carried an ICL for all of you all. You know?
Unused one.
Unused one.
Unused one. Because these people won't give for anybody else.
Okay. Yeah, so we thank you for so much details about the other not so important surgeries. The more important surgery is the ICL. And why ICL? So I would say, why not ICL? Okay, because here we are talking about to touch the cornea. I mean, they haven't really gone in the depth of what happens if the cornea really gets spoiled. So before I quickly go on to why ICL, I'm just going to be saying that ICL is a relatively new intraocular lens that can be implanted into the eye without removing the natural lens. So here, if you nowadays there's been so much of clear lens extraction with higher myopes. Here we have the benefit of the natural lens still being not removed and accommodation being preserved. So this lens is a good choice for everything, for myopia, hypermetropia, astigmatism. So we have a whole range of patients that we can treat with because of ICL. So what are the advantages of ICL over the other two procedures that we are talking about? First and foremost, high powers. As we all know that not all powers can be treated by SMILE or by means of Contura LASIK or LASIK. So ICL, the Vision ICL is FDA approved for myopia up to -20. And their toric version can correct astigmatism in the range of 1 to 4 diopters. This is one of the most important points about ICL, which the other two cannot go up to as high as that. Thinner corneas. Obviously, when there are thin corneas or there is keratoconus or there's any issues with the cornea, you cannot touch the cornea. And that's where ICL comes in picture. ICL has no minimum corneal thickness requirement in contrast to LASIK or SMILE. Third is a very, very important thing right now is dry eyes. I think we have so many patients who are complaining of dry eyes. Dry eyes become by itself a big issue. And here with LASIK, we are cutting down the nerves, leading to dry eyes. In ICL, there is no touching of the cornea, so it does not disrupt the corneal nerves like in LASIK. So when and where to opt for ICL? One of the biggest benefits of ICL is, as Madam had said, that if there are issues of either cataract or glaucoma, or if the corneal touch is there, it is very, very easily reversible. We can remove the ICL and treat the issue if there. Whereas here, there is no reversal that's possible. ICL offers ultraviolet protection to the inner eye, including the macula. Again, no such advantages. And the stability of the cornea is maintained. So ICL surgery does not modify the curvature at all, whereas here there are obviously changes that are needed. So there have been studies on this as well. A recent study in 21, there's a comparison between ICL as well as and SMILE, and it says that to compare the efficacy, safety, predictability, and quality of vision between ICL and SMILE, and ICL implantation can be a better choice with higher myopic correction in adults. And another one that talks about the higher order aberrations, and it says that the ICL and TICL perform well in correcting high myopic astigmatism without significantly changing the higher order aberrations. but although there is little amount of changes. Now ICL has also come with, IPCL has come out with the bifocal IOL, which treats distance as well as near. Of course, we are waiting for better lenses to come in. This does give a little amount of pupillary pigmentary dispersion and halos, but we are looking forward to better presbyopic ICLs coming in. So to conclude, that ICL has its unique set of pros and cons. Overall, it's a great option to get rid of glasses and improve a patient's lifestyle. It's safe, quick recovery, and has small learning curve. If encountered with any complications like cataract, high pressures, or corneal epithelial loss, then it can be removed and it can be treated. Thank you so very much.
So we'll start with the show of hands. Let's have a vote for smile. Okay. No, if you have all the machines. If you have all the machines, then the patient is fit for everything. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Is it because you want the machine or you want the patient to get smile? The second is Contura. Contura. 2, 3, 4. 4. And this is also if you have all the machines. And last is ICL, for which you don't need any machine.
Can we put our legs also?
Okay, so I think we have. I think if you enjoy surgery and you're a good surgeon, you really enjoy smile. But you need to market smile because ICE doesn't know how to do that. And if you want somebody to do the marketing for you, then you should buy Contura, and it is really the simplest procedure to do. I mean, I think after PRK, Contura is simpler. But the thing is that I think Contura is definitely an advancement in terms of being a faster laser. The visual recovery is great. And finally, ICL, I think it is a great tool for people who don't have access to machines and patients still need the visual freedom from glasses. And for us, 10 diopters is really a cutoff. So for suspicious topographies and for very high, we always gravitate towards the ICL. So thank you.